Welcome. Good evening, all my friends, for the fifth webinar of DFSI. Today we have Dr. Ashu Rastogi, Assistant Professor, Department of Endocrinology and Metabolism from PGI Chandigarh, enlightening us about diabetic peripheral neuropathy and diabetic foot. We all know that at least 50% of our diabetic patients suffer from neuropathy. It is one of the commonest complications of diabetes. Only few of them have pain, but rest of them many of them are asymptomatic and they go unnoticed. And we also know that that is the beginning of the diabetic foot problems. So early detection in an asymptomatic patient is also equally important. So how do we do it? And what are the pathophysiological mechanisms? What is the current practice or current evidence regarding that? I think Dr. Ashu will be able to tell us all about that today in the lecture. Ashu, on to you. Before that, let me tell you that we have a very good speaker today. Ashu happens to be a fellow of American College of Endocrinology, and he is also a fellow of Royal College of Physicians, and he has bagged Young Investigator Award by American Association of Clinical Endocrinology, ACC, in 2012, and he has also, to his credit, the best research paper in International Diabetic Foot IWGDF meet in 2017, and he also has got AR Sheth Award by Endocrine Society of India, by outstanding paper by US Endocrine Society. He also has got A.V. Gandhi Award, again by Endocrine Society of India. He presently is Vice President of DFSI and Treasurer of RSSDI Chandigarh, Punjab chapter. So you cannot have a better person than Ashu to talk about diabetic peripheral neuropathy and diabetic foot. On to you, Ashu.
Thank you, Dr. Aarti, and it is really a pleasure so that we can communicate in these difficult COVID times to all those people who are interested in diabetic foot. And we already have in very exhaustive and very complete lectures, past 4 lectures. So I'll be just covering another aspect of diabetic foot, and that is about diabetic peripheral neuropathy. Because we know that this peripheral neuropathy is definitely the forefather of the diabetic foot, and if you don't recognize it, then you are likely to have your patient in trouble and yourself in trouble also. So this is the place from where I come. This is my institute, Postgraduate Institute of Medical Education. It is just situated north of India, and it's really a beautiful place. You are always welcome to visit us at PJMR Chandigarh, and this is our entry gate. So regarding disclosures, I have no conflict of interest regarding any part of the presentation, but yes, I'd like to thank Dr. Arun Bal for giving me permission to use some of his work and some of the slides I have borrowed from him. So my purpose is to give you some answers during the next 30 to 40 minutes. And as Dr. Aarti has already elaborated, so I'll be telling you about how common is a peripheral neuropathy in patient with diabetes. And mind it, even my residents also don't know how to define diabetic peripheral neuropathy. So you should be very sure once you are seeing a patient with diabetes, what exactly is neuropathy. You should know how to classify it. And most importantly, you should exclude very common disorders that these patients have, which might also lead to neuropathy, and it might not be diabetic peripheral neuropathy. When to screen and how to assess for diabetic neuropathy, how to diagnose, how to approach, and finally how to treat peripheral neuropathy. And most interesting aspect of my presentation would be about a link between a diabetic neuropathy and diabetic foot. And finally, we have a lot of work which is done in India itself about the outcomes of the neuropathic foot ulcers that I'll be elaborating upon, and finally the take-home message. So this slide is a very interesting slide, and you can see from the left-hand graphs that the prevalence of neuropathy even at diagnosis is 10% in patients with type 1 diabetes, and it's around 20% in patients who have type 2 diabetes. So you can see here. Now with increasing duration of diabetes, suppose a patient who comes to your clinic who is 10 years duration of diabetes, you can find that almost 30 to 35% of patients would have neuropathy. And suppose if you miss the examination for neuropathy, that means this is bound to have trouble. Similarly, you can see that with increasing age, the duration of diabetes also increases, but with increasing age, also the neuropathy increases. And most of our patients usually come at the age of 50 to 60 years. So almost around one third of these patients would have neuropathy. So it's very important that we should not miss this is as one of the important complications. Now, what does this slide shows? This slide just shows that how many of the patients are diagnosed diabetes because of peripheral neuropathy. And you can see that amongst this is a cohort from a small country, but what they have shown that almost all those patients who came to their clinic, they had some symptoms of neuropathy that brought these patients to the clinic. And therefore, it becomes again important to do a thorough examination for these patients. Coming on to the definition of diabetic neuropathy, and this is a standard recommendations by American Diabetic Association, and they say that presence of signs and symptoms of neuropathy in patients or people with diabetes is called diabetic neuropathy. And this might seem a very vague definition, but this is very important. What they say that diabetic neuropathy is basically a diagnosis of exclusion, and almost 50% of these patients may be absolutely asymptomatic. And here comes the role of signs of neuropathy that you as a clinician, as a physician, have to elicit once they come to your clinic. And out of all forms of neuropathy that I'll be telling you, the distal symmetric polyneuropathy, that is both motor as well as sensory, is the most common form of neuropathy. And unfortunately, if we don't recognize, then preventive foot care we cannot implement. And finally, the patient's foot would be at risk for injuries and ulcers. So this is about the differential diagnosis, because we know that diagnosis of diabetic neuropathy is a diagnosis of exclusion. So it's very common that we should rule out certain disorders which also have a very prevalent neuropathy, and one amongst them is hypothyroidism. So thyroid disease is very common. You should at least do a thyroid function for those patients who are coming to your clinic with neuropathy symptoms. Renal disease because of uremic neuropathy, some systemic disease, and we are commonly seeing paraproteinemia, and that is because of some kind of malignancies, a myeloma, and even amyloidosis can also present with neuropathy. And this is very, very common in those patients who are usually elderly, maybe around 60 or 70 years of age. Infectious neuropathy because of HIV, hepatitis B, we have seen these patients. And inflammatory neuropathy like CIDP, this is very common referral from our neurology colleagues. And nutrition neuropathy minded, it's again very, very common. We have seen, especially in this part of the country where alcohol is so common, thiamine deficiency can also lead to neuropathy. So you just need to rule out these common forms of neuropathy. Regarding the symptoms and signs of neuropathy, for the definition of neuropathy, what is important is that patient can have both the symptoms related to involvement of large myelinated nerve fibers, or it can be because of the small myelinated nerve fibers. So if it is large fiber involvement, then patient usually complain of some kind of numbness, tingling, or a poor balance, and they tend to fall frequently. While it is small fiber involvement, which is much more common, much more earlier as compared to the large fibers, the patient usually have positive symptoms. And positive symptoms like those symptoms which are not present in a normal person like me and you, but a patient of diabetes would have them, like a burning sensation in the foot, or electric shock, or stabbing like sensations. So these are common symptoms that the patient might present with you. And what you need to do is elicit these signs or by doing examination. You can do an ankle reflex vibration 10-gram monofilament, which we'll see in future slides. And for small fiber, we usually test the temperature sensations and also the pinprick sensation. This is just to elaborate the classification of diabetic neuropathy. I don't want to go into the detail, but it's important that you should just know that diabetic neuropathy is usually divided into mainly three forms. Two forms are mainly important. One is diffuse neuropathy, that is most common form. Involvement of small fibers or large fibers, this is very common, as I told you earlier, and you can differentiate between small and large, but sometimes what we see is mixed form is much more common. Autonomic neuropathy has its own importance, but I'll not be covering because this is a very huge topic. But remember, diabetic mononeuropathies are also very important, and we see patients who come with seventh nerve palsy or even third nerve palsies, and this is again because of diabetes. But don't forget that even in these patients who have these characteristic signs and symptoms, there are some common forms of neuropathy which are not because of diabetes, but they're otherwise common in diabetes as compared to general population, like pressure palsies. This includes the carpal tunnel syndrome, tarsal tunnel syndrome. These are also neuropathy, which is otherwise common in patient with diabetes. The chronic inflammatory demyelinating polyneuropathy, like CIDP, is also very common, and radiculoplexus neuropathy. So just remember a simple classification of diabetic neuropathy. Now, as I have told that both motor as well as sensory neurons are involved. So if a patient is having sensory neuropathy, what will happen is he'll have a loss of sensations. And this is the most beautiful sense that a God has given to us. But unfortunately, if we lose sensations, there will be inability to feel increased pressure, and patient would lose position sense, and then patient would have changed walking pattern. This is important to note. Also, if a patient is having motor neuropathy, he will have muscle imbalance and weakness, which can lead to deformities. And this is very common, like hallux valgus deformities or hematodeformities, which are very, very common in patients with diabetes. So they will have a changed walking pattern, and you can identify these changed walking patterns on examination. So they would have hyperpronation, and they also have increased first metatarsopharyngeal joint contact time. So this is important to recognize the motor neuropathy and sensory neuropathy. I'll show you some examination points that you need to know while just seeing a patient of diabetes. But this is the ADA 2020 recommendations, and what they say that if a patient who comes to your clinic on the very first day he is a type 2 diabetic patient, you should screen for diabetic neuropathy. But if a patient is type 1 diabetic, you can do an examination for neuropathy 5 years after the diagnosis of type 1 diabetes, especially if the type 1 diabetic is a child. And after that, you have to do an annual examination. So if you have decided you have to do an examination, it's important that you should know how to do it. And importantly is a very careful history taking, especially about the positive sensations, the negative sensations, rule out all other causes of neuropathy other than diabetes, history of hypothyroidism, any substance abuse, alcoholism. After that, you can just do a simple test. For small fiber, either you can do a temperature sensation or you can do a pinprick. Now, pinprick is very easy to do. You can just take a nail pin, and by that you can do a pinprick sensation. Vibration using a 128 Hertz tuning fork for large fiber sensation. But in addition to it, you should always do a 10-gram monofilament test. Now, what is this test? This test is the most important test to diagnose the pressure sensation and also the touch sensation, because it has been seen the loss of monofilament sensation makes the foot at very high risk for foot ulceration and diabetic foot, and later on amputation. The guidelines also suggest that electrophysiological testing may be like nerve conduction velocities that neurology friends are so fond of doing. It is not recommended to do unless you are thinking some other kinds of neuropathy which is other than diabetes. Now, coming on to the basic examination, so even before the patient comes and sits onto the stool in your clinic besides you, the patient opens the door, enters the clinic, you can just observe him. You can observe the gait of a patient. That can tell you so much about neuropathy. You can check the balance of a patient while he's walking and coming to your table. You can see the stance, how does he stand, what is his posture. You can see whether he is very sluggish in walking, whether what is the step length, symmetry, the cadence of walking, the fluidity of its movements, and also instability. So these small points, just you do not need to remember these, but you can look at the patient while he is entering into your clinic. So suppose if a patient is having very high stamping gait, it is suggesting of a sensory neuropathy because he has lost his sensation. Therefore, he is stamping his foot on the ground. Now, while walking to the table, your table, if he loses his slippers, that suggests a sensory neuropathy and also components of motor neuropathy. If he is having a foot drop, then he will just scrape his foot over the floor. And if he is walking comfortably, but still you see that he is having an ulcer, that means that he has completely lost the sensations over the foot, and that is suggestive of severe neuropathy. And the antalgic gait is suggestive of neurovascular kind of phenomena. Now, this is a simple test that I want to highlight, and this does not require any gadgets, which has a very good sensitivity and specificity to diagnose neuropathy, which is very quick to administer. Now, what you do is ask the patient to sit calmly on your chair. Then you ask the patient to rise from the chair without using the arms of the chair, and ask him to walk a meter, turn around and come back to the chair and sit down. What you need to do is you just need to know how much time does it take to do this. Suppose if it takes less than 10 seconds, this is a very normal phenomenon. But unfortunately, if it takes more than 20 seconds, that means he is having neuropathy, and that means he is having some gait impairment, and you need to examine this patient very carefully. Also, even before using any kind of tools, just look at the skin. If it is dry, it is suggestive of autonomic neuropathy. Patient is having turgid veins, autonomic neuropathy with AV shunting. Look at the nails. If they are hard but brittle in scenes in neuropathy, loss of hair is sign of vasculopathy. If the skin is red, it is a sign of inflammation. Always look at the web space, and callus and corns are again signs of neuropathy. So regarding the use of tools or the standard clinical examination of neuropathy that we always ask. So what they say is monofilament, as I said, has to be done in all the patients. And in addition to it, you can choose any of these two tests out of pinprick, tuning fork, ankle, and bathymetry. And after doing this, you should be able to do this DNSS. DNSS just stands for Diabetic Neuropathy Symptom Score. So this is a tool of just 4 symptoms that you can ask from a patient, and if he has 2 out of 4 symptoms, that means he is having neuropathy, and that has been well established, especially by work done from Andrew J. Bolton in England. And neuropathic disability score is also a very important tool. And if they say that if the patient is having a score of more than 6 out of 10, then it suggests that this patient is at very high risk of developing a foot ulcer in next 1 year or 3 years, and they need your consultation and a protective footwear also. So this is from our clinics. This is from my just bed rounds that I take during the examination. So these are the sites on the foot at which you have to put a monofilament. The monofilament is a 9-hole monofilament which has a thickness of 0.5.07 and which has a weight equivalent to 10 gram of linear force. And it usually tests large fiber functions, mainly touch, and you have to test at these 5 sites, mainly the ball of great toe, first, third, and fifth metatarsals, and the heel. And even if the one test is negative, that suggests that the patient is having neuropathy and is at risk of foot ulcers. So if you have facilities, this is our foot lab where we have all automated neuropathy analyzers. This many of you might also be possessing. Just within a minute, you can have assess neuropathy. You can check for vibrations, the temperature sensations which are carried by A delta fibers, and also you can check for pain perception, C fibers. Both hot and cold temperature sensation are important because it is noted that it is the cold sensation that is lost earlier in few of the patients who are likely to develop Charcot's neuroarthropathy, and it's hot temperature sensation which is lost earlier those who are likely to develop foot ulcers. So this is a few of the papers that have suggested this kind of a differential pattern of neuropathy. But suppose you are sitting in maybe a village, you are sitting in a primary healthcare center where you don't have facility of this automated neuropathy analyzer. That doesn't mean that you should not diagnose or you cannot diagnose neuropathy. So even in these patients, you can diagnose neuropathy. And this is a simple tool that was developed by Gary Raymond from Southern England, and again from the city of Ispwich. So it's named after his city, that is called Ispwich test. It's all the touch test. And this is a very, very simple test. What they do is, you just ask the patient to lie supine and close his eyes. Once he closes his eyes, you sit onto the side of his foot, the plantar aspect of the foot, and you touch the toes from top, a light touch. You touch the 3 toes on the right foot and the 3 toes on the left foot. And you ask the patient to just say yes or no whether he can perceive your touch sensation. If a patient, and you can see from this photo that this is how we touch the toes of the foot, a light touch. So the patient should not be able to see your finger because his eyes should be closed. And if he cannot perceive more than 2 touch, that means his foot is insensate. And this is found to have very high sensitivity and specificity for diagnosing neuropathy, and that has been validated. This was a paper in 2011 in Diabetes Care, but it has been further validated in many other papers that have come up further. So remember this test, no tools, nothing, no cost, a simple test which can be done in your clinic at bedside. Now this is just a comparison of all these tests. This is a paper from our department in IJMR in 2011. What we did, we just compared all these tests to diagnose neuropathy, and we found that tuning fork has a very good specificity for diagnosing neuropathy. So using a 120 Hz tuning fork is very good test. You can also do an ankle jerk test and monofilament to diagnose neuropathy. So this slide is again very important for we physicians and also for those people who are looking after diabetic foot. Remember that there are some kind of neuropathy because it is sometimes told that diabetic neuropathy is usually irreversible. But remember, there are few kinds of neuropathy which can be reversed. One of them is AIDP or CIDP, where role of some immunosuppressants has been there. But it's important that you should be able to diagnose chronic inflammatory neuropathy, which is again very common in patients with diabetes, and this is also known as CID. You would also be able to diagnose focal and multifocal diabetic neuropathies from the first, the left hand side, which is the most common form. So this is the most common form of neuropathy, which is the length dependent diabetic polyneuropathy. So this is the most common. It is usually present in the foot and at night. CIDP, though uncommon, but it need to be ruled out. And again, focal neuropathies are very common. Motor deficits, if at all, is present in DSPN or length dependent neuropathy, is usually distal. In CIDP, it is much more common and it's proximal. Mainly the thigh muscles would be involved so that the patient would not be able to get up from the sitting position. And again, in focal neuropathies, it is common, but it would be asymmetrical, present in one leg and not present in other leg. Sensory losses are very, very common. They usually present with pain and temperature loss. And this is variable presentation in focal neuropathies. And dysautonomias, which is common in patients with diabetic neuropathy because of autonomic neuropathy, is very uncommon in any other kind of neuropathy. You can do electrophysiology, and we also do some kind of nerve conduction velocities for these patients once we are confused whether we are dealing with diabetic neuropathy, because if a patient with diabetes has mainly thigh muscle involvement, it is an alarm bell. That means you should think of some other kind of neuropathy, and most common it would be a CIDP, and this is mixed form, and they usually have demyelinating pattern on NC. The treatment with IVIG has been shown to have, or steroids have been shown to have a good response if it is CIDP. So just this slide I want to show to rule out other causes other than diabetic neuropathy. Now coming on to the most important aspect what we have gathered today is I'll be spending just 10-15 minutes, half of my presentation, about a link between neuropathy and diabetic. So for the past slides I have told you how to examine a patient who can have a motor neuropathy. So if he's having a motor neuropathy, he'll have deformities, motor imbalance. If he has a sensory neuropathy, he will have a loss of protective sensation, which is also called LOPS. And usually these patients have a combination of these two, and this makes our foot much more prone for impact, trauma, insensation, and the development of foot ulcers. So this is our paper where we highlighted, this is a paper we highlighted that what kind of foot ulcers we see in India. So what we have noticed is that almost 2/3 of diabetic foot ulcers in India are neuropathic foot ulcers, and only 1/3 are neuroischemic ulcers. Coming on to the Caucasian or the Western cohorts, mainly studies from England and Europe, they have shown that almost half or 2/3 of their patients have vascular ulcers or ischemic ulcers. So in our context, maybe diabetic neuropathy is much more prevalent, and this is likely to develop foot ulcers. So we have, as Indian patients, we have to be very cautious while dealing with diabetes. So diabetic foot is one of the most devastating complication, and unfortunately, you can see the bad healing is much more common in patients of diabetic foot ulcers, especially the neuropathic foot ulcers. And if they get infected, 75% of these may land into some trouble. Unfortunately, maybe because of lack of medical care and insufficient knowledge and lack of trained personnel, the management of these neuropathic foot ulcers again become a challenge. So this is important that we should know that what exactly leads to these neuropathic foot ulcers in Indian scenario. This is again a paper that we have written, and we have shown that a simple things that makes these problems much more common in Indian scenario. One is a barefoot walking. So this is very common, maybe because of our cultural practices or our religious beliefs. People usually walk barefoot, and if they have diabetes, they will have neuropathy, and finally they will develop ulcers. Unfortunately, they try some alternative medicines, and once they come to the centers, which are usually not apt for this treating the diabetic foot because they are not diabetic foot centers, they usually are mismanaged. So lack of trained personnel in foot care centers in India is also a problem, and an out-of-pocket expenditure also leads to this problem of neuropathic foot ulcers. So this is how that we can differentiate between a neuropathic foot ulcer and an ischemic ulcer, because we are dealing with neuropathy. So you should know when a patient comes to you with an ulcer, it is basically a neuropathic foot ulcer or a ischemic foot ulcer, because I will not be covering a ischemic foot ulcer. So usually neuropathic foot ulcers are present at pressure points, and pressure points are usually on the plantar aspect of the foot, mainly at the ball of the great toe or the metatarsal heads, the first, third, fifth metatarsal head, and also the heel. But suppose if the patient is having a flat foot or the patient is having rocker bottom deformity, he can have a pressure ulcer also on the midfoot region. But the ischemic ulcers are usually present at sides of the foot, along the tips of the toes, at the end of the toe. Usually the toes are involved in ischemic foot ulcers. pain is usually lost. This is a characteristic of neuropathic foot ulcer. Unlike the ischemic foot ulcer, when the patient would have claudication, also the patient would have severe rest pain. Callus, if a patient is having, that is a sine qua non of a neuropathic foot ulcer. So if you see a callus, it is neuropathy. It is neuropathic foot ulcer. The pulses would be present in neuropathic foot ulcer, would be absent in ischemic. ABI you should always do in these patients. Usually they have normal ABI, and usually if you properly treat the patients of neuropathic foot ulcer with adequate debridement, good offloading, a good healing can be expected. Unlike ischemic foot ulcers, where you might need to intervene, and they usually have a poorer prognosis as compared to neuropathic foot. So this is the second last part of my presentation, and it usually deals with another aspect of neuropathy, and this we as a physician are very afraid of, because this is very challenging to maintain, challenging to manage, and patients are so much worried and so much in trouble because of painful diabetic neuropathy. And this is defined by the Toronto consensus that painful diabetic neuropathy is a kind of pain that arises as a direct consequence of any abnormality in the peripheral somatosensory system, which is responsible for painful diabetic neuropathy. And you remember that almost one fifth to around one fourth of patients will have a painful diabetic neuropathy. Usually they would have severe pain in their foot or the calf. It is usually distal. It's also symmetrical, and usually it's very, very severe at night. The patient will come, doctor, I have very severe pain at night, and especially on my foot. Kindly do something. What kind of pain? They usually explain that it is a deep aching pain, sometimes electric shock, sometimes burning. But what is important is they might also have hyperalgesia. Hyperalgesia means a kind of a pain noxious stimuli that is perceived excessively as pain by a patient of diabetes, and allodynia is a stimulus that is not perceived as pain by a normal person, but unfortunately a diabetic patient would perceive it as pain. Like just simply you touch the patient of the foot of a patient of diabetes and he'll cry with pain. So this is allodynia. So this is all a feature of painful diabetic neuropathy, and mind it, we have seen even suicides because of painful diabetic neuropathy. It significantly impairs the quality of life. It's very difficult to treat, and it is a very complex pathophysiological mechanism because of changes in multiple ion channels, sodium, calcium, potassium channels, also some amount of neuropeptide abnormality expression. It's both at the central level as well as the peripheral levels, and usually it's a dorsal nerve root ganglia that is responsible for just sensing this pain sensation, and this is abnormal firing of these neurons that lead to development of pain. So you can see the irony. In the first part of my presentation, I was telling you that these patients usually lose the gift of pain, but unfortunately few of these diabetic patients have another kind of neuropathy, that is painful diabetic neuropathy. So it's very important to know this and manage this. So what the guidelines also suggest that if you are choosing a drug, it should be successful, and the success is defined as if a patient can obtain at least a 50% reduction in his pain levels, and pain we usually assess by visual analog scales. So if a drug can reduce his pain by 50%, this is a good success. So just remember, a 50% reduction is a good success for whatever treatment for painful diabetic neuropathy you are using. It should have some additional benefits, like it should be beneficial in sleep and also improve the quality of life. But unfortunately, whatever drug we are having at present, only 50% of the patient get relief, and many of these patients do not get relief. So this is some of all the guidelines that I have put forward in the slide, and it shows that the first line treatment always remains either the tricyclic antidepressants like amitriptyline or duloxetine, and pregabalin, which can also be used as a first line agent, which is recommended by American Association of Neurologists and also by American Diabetes Association. But remember, there are only two drugs that have been FDA recommended or approved for diabetic neuropathic pain. One is duloxetine and second is pregabalin. But unfortunately, sometimes you might see that patients are on adequate dose of duloxetine and pregabalin, still they don't improve. Then you have to add on a tricyclic antidepressants, and suppose a patient still does not improve, you might have to use some other modalities like capsaicin creams. You can also use opioids like tramadol and tapentadol. So this can give you a simple guide that what you should choose. Most important is a glucose control, because glucose control has been seen in UKPDS that it can prevent neuropathy, It can also be useful to reduce the symptoms of neuropathy, and it also used to prevent neuropathy. Glucose control is most important, but remember, if the patient is having significant symptoms, sorry, so if the patient is having significant symptoms, what you need to do is you can choose either gabapentin or pregabalin. So pregabalin is the most common drug that we use for patients of neuropathy. And if the patient does not improve on adequate doses of around 150 to 300 milligram, we usually add duloxetine and sometimes tricyclic antidepressants. So out of all these, we have to initiate with a single drug, and if the patient does not improve, then you have to choose a multiple of these combinations for treating your patients of neuropathy. So this is a simple table that you can definitely take a snap out of it. This is a very important table, and that helps you in choosing neuropathy drugs. Suppose if your patient is very obese, out of duloxetine or pregabalin or TCA, what should be used? So the best drug in obese patient with neuropathy is duloxetine, because both pregabalin and tricyclic antidepressant usually cause weight gain. Therefore, I have put them a arrow down. That means they should not be used. If a patient is depressed, definitely tricyclic antidepressant should be used. If a patient is having coronary artery disease, this is very, very common because these patients also have macrovascular complications. So ideally, you should not use TCAs because that they can worsen the ACS or MI. If the patient is having a very high blood glucose, ideally you should not use duloxetine or TCA because they have been shown to increase blood glucose. So the best drug in this scenario would be pregabalin. If the patient is hepatic failure, again, a choice of drug can be pregabalin or TCA or opioids, but never duloxetine. If a patient is having renal failure, then you can choose TCA, but duloxetine preferably should be avoided. And if a patient is elderly, ideally you should not use TCAs because they can lead to severe symptoms. Mainly, they are symptoms of bladder disturbances and severe cholinergic symptoms that are seen with TCAs. So you can choose either duloxetine or pregabalin for this patient. This is a simple guide to choose what drug you should use. Now, there have been a lot of non-pharmacological therapies for neuropathy, and I'll not go into the details. People here using acupuncture, laser therapies, and many other kind of neuropathy. But this is anodyne therapy, which I have highlighted in red, and we have experience with anodyne therapy. This is also called infrared light therapy, and this is very useful. And we have done a randomized trial for this in neuropathy, and which is painful neuropathy. So what we did, this is a sham controlled trial, and we found out that this Maya therapy significantly improved the quality of life of the patients. It improves their pain so that they do not have this pain, and this visual analog score was used to assess their pain, but it does not improve the basic pathophysiology. And that was, we also did a biopsy of the nerves, and we found out the intraepithermal nerve fiber density for these patients. So if you have facility, if you have this machine, definitely it is found to be useful in painful diabetic neuropathy. So this is one of the last part of my presentation, and because we have studied about the prevalence of neuropathy, the how to diagnose and how to treat with drugs, but you should know that missing neuropathy can be a challenging thing, and you should not do that. So this is the largest study that has come up from India, and this is 7 centers all across India where Dr. Rajesh, Dr. Bal, and from people from Amrita Institute, and also from Calcutta, and also from England and US, Dr. David Armstrong were the part of this study, which was published in DRCP journal. And the main aim of this was to follow those patients who have neuropathic foot ulcers. What happens to these patients as compared to a patient of diabetes who does not have a foot ulcer? So this is a large cohort study of more than around 3,000 patients who were followed for a duration of 8 years. And interesting to note, we found out that almost 1/3 of these patients of neuropathic foot ulcer have some kind of amputations. And this can be a minor amputation or major amputation. And the major amputation was mainly the pillow-knee amputation, and a minor amputation like toe amputation. So remember, even a neuropathic foot ulcer can also lead to significant amputations. Therefore, you need to prevent it. And this data was presented at IWGDF meet at Hague, Netherlands in just 2019. And we also found out that almost 1/5 of these patients die early as compared to a control cohort who were diabetic but who did not have neuropathic foot ulcer. And this is shown by this slide. So around 16% of patients of neuropathic foot ulcer died over a period of 8 years, compared to 3.1% in controls. You can see from this Kaplan-Meier curve that if a patient is having neuropathy, on top of that he develops foot ulcer, he is likely to die. So you have to diagnose it very early, and these are just the causes of death. This was the paper, and this is another aspect of neuropathy that I want to show from this foot photograph. You can easily diagnose that this patient is having flat foot or swelling, which is erythematous, and usually over the midfoot mainly, and the hindfoot is also swollen up. So this is a typical characteristic of this is the X-ray of a patient. Unfortunately, nobody did an X-ray. He was continued to walk over this neuropathic foot because he'd never sensate. And this is a characteristic picture of Charcot's neuroarthropathy or vanishing bone disease, which is again a presentation of neuropathy that we published. Now, this is a paper that again presented in IWGDF meet at Hague, Netherlands, and this was awarded as the best paper in that meet. We got even a grant of 1,000 euros for this paper, a prize. And this is about the follow-up of patients of Charcot's neuroarthropathy. Earlier was neuropathic foot ulcer, and if a patient is having neuropathy and Charcot's also, we want to know that what is the mortality rate of these patients. So this is a large cohort of 260 patients, and we found out that even in patients with Charcot's, around 1/3 of these patients also have ulcers. They can present to your clinic with ulcers, and mainly it is because of deformities like flat foot or rocker bottom. 15% land into amputations, but interestingly, they have a very high risk of death, and you can see that their risk of death is around 3 times more as compared to a person of diabetes who does not have neuropathy or Charcot's. So my humble request to you is that always examine your patients, because diabetic neuropathy is killing. It can kill your patient if you miss your patient. And how to follow your patients? Always do examination annually, as I told you. If a patient does not have sensory neuropathy by your clinical examination, you can safely ask a patient, please come after 1 year, I'll again do a neuropathy examination. But suppose if a patient is having sensory neuropathy, you should repeat the examination every 6 months. If it is having sensory neuropathy along with peripheral vascular disease or any kind of deformities, if a simple hallux valgus or a hammer toe, you should ask your patient to follow every 3 monthly. And unfortunately, if a patient has a history of ulcer or a simple, even a digit amputation, you have to call your patients every 1 to 3 monthly, do a thorough neurological examination. So I hope that I have completed in time. Exactly 40 minutes were allotted to me, so it's 37 minutes. So I will conclude by these few statements that the best treatment in neuropathy is only slightly better than the worst. So it's better to prevent all this. Prevention of diabetic foot is the essence by a very early recognition of neuropathy, as Dr. Aarti has already told you in introduction. So this was the essence of this presentation, and that can be done through periodic screening by using simple examination and tools that I have elaborated. An annual examination of peripheral neuropathy is essential, and you can do more frequently if signs and symptoms are present. Treatment has to be individualized. Remember, if this patient is having neuropathy, you might need to give him a good footwear, a good offloading device. If he is having a neuropathic foot ulcer, he needs more care. Maybe he might need a total contact cast also for the healing of the foot ulcers. And remember that neuropathy and neuropathic foot ulcers have very poor prognosis, both for the limb and also for the life. That is the data from the study from India. We need a dedicated team and understanding the local milieu of the R. And this photo we took, and me and Dr. Rajesh was there at the Hague. This photo I took from Hague. We were just jogging on the shores of Hague, and we found out this mural. You can see this gentleman is just watching the plantar aspect of the foot. So what is important of this photo is always counsel our patients to examine their foot for any kind of abnormality, because if the foot is insensate, even their pin might be inserted over the plantar aspect and they might not notice. So this empowering our patient for self-examination is also very important. And remember, a simple physician and a diabetic foot specialist can do many more things. And in the words of Dalai Lama, if you think that you are too small to make a difference for your patients of diabetic foot or neuropathy, try sleeping with a mosquito. Even a single mosquito can make your life or a night hell. Thanks for patient listening. Now, Dr. Aarti, it's up to you.
Yeah. Thank you very much, Ashu. Of course, it was very lucid, and most important thing is it was very inspiring. You know why? That is because you made it sound very, very simple. and the slides came one after another. So the flow was extremely good. I'm sure at least a few of us who are not very used to doing the tests frequently will be able to do it henceforth. So it's a must. Examine all your patient's feet properly and document it. And you'll have to ask the patient to come again at the appropriate time depending upon his test results for follow-up and keep the patient for good follow-up. So it's very important. I have a few questions, Ashu.
Yeah.
I just go one by one. Yeah, from Nagarkoil, they just want to ask you, Dr. Manakala Perumal. So he wants to know whether drugs do really help or it's just the diabetes control that helps in peripheral neuropathy.
So if you are asking about the prevention of neuropathy, definitely the glucose control definitely helps in prevention of neuropathy, and we have best evidence from UKPDS trial, is the largest trial, and that has shown that good glycemic control by the memory effect can prevent neuropathy by around 25 to 30%. So this is very important. Regarding the use of drugs for prevention, if you are asking, none of the drugs has been used for prevention of neuropathy other than those used for oral diabetic good glycemic control. So this is important. You should not try off-label drugs for prevention of neuropathy.
Maybe they were trying to tell you about some nutrients or something like that. I think other than well in a metformin patient, right?
Yeah. So I can just a few words about that some nutrition supplements and prevention of neuropathy, because yes, I agree that you can have some kind of vitamin deficiency neuropathy like B12 deficiency neuropathy or thiamine deficiency neuropathy. So we usually supplement our patients with B12, and especially if the patient is alcoholic, we use a supplement with thiamine and B12. You can do that, but that is not a dictum that it can prevent neuropathy. Yes, metformin, madam has elaborated, and recent guidelines have also shown that if patient is on chronic metformin therapy, the Diabetic Association recommends to do B12 levels in all our patients, especially if the patient is vegan. So you can do a B12 levels, and if it is low, you can supplement. But irrationally supplement B12 and irrationally doing B12 is not justified. It's costly.
Yeah, and then we have one more question. Um, is there any specific diet which can prevent a neuropathy?
So there have been no trials regarding diabetic neuropathy and prevention with diet. Yes, diet does improve glycemic control.
Patients.
Yep.
I do not understand whether they meant it for prevention or for treatment.
So even for treatment, what they say is that good diet definitely can prevent the upswings in glucose. And definitely, you know that if patient is having very poor glycemic control, he would have symptoms of neuropathy. So diet control is very, very important, but no specific recommendations for the treatment or prevention of neuropathy and diet has been advised in any of the recommendations, whether it may be ADA, ESD, or even ACE. But yes, good diet as otherwise recommended for diabetes should be there. Especially, I have highlight regarding the use of 5 servings of fruits and vegetables. That is important. That can give you good amount of vitamins. That should be there, but not specifically for neuropathy.
I put it as a balanced diabetic diet should be the diet for everybody, including those of diabetic food. So I customize it.
Absolutely.
Okay. So and then we have a question about allodine therapy, how useful it is, and what's your experience? I think you've already spoken about it. Maybe you need to elaborate a little bit.
Okay, just 2 lines about that. If you have facility for anodyne therapy, one thing is very patient friendly, because patient feels that because it does not lead to any abnormality or any abnormal sensation to the foot. Patient just lies down. We wrap the pads over the foot, and what we have seen that it definitely improves the quality of life. We studied this by Norfolk quality of life scores, and they were significantly improved with this anodyne therapy. And the visual analog score, the pain symptoms also improved. But unfortunately, I will highlight one thing, that once you stop doing anodyne therapy, again the patient start perceiving pain. So probably it is difficult. It might not have long-lasting effect, but for some patients who are having severe pain, it is useful.
Can I ask you something? How cost effective it is?
Ma'am, I'm not the right person, because we do free of cost from a government. I'm from a government institute. I don't know anything about cost of that.
Because I think that cost effectiveness is an issue because the patient needs to come to you again and again for
You
the
are right.
So,
Yes.
and then recurrent visits to the hospital themselves are very costly.
Yes, true.
So, maybe from cost-effective point of view, it might not be in favor of the patients, and that is what is my understanding currently.
Possible. Possible.
The next question would be, what is the maximum dose of pregabalin and gabapentin in a severe painful DPI?
Okay.
And we give morning dose.
Okay.
In your opinion, about the combination with methylcobalamin, etc.
Okay. So regarding pregabalin, we usually start with the dose of 75 milligram. The recommended dose is usually around 300 milligram, and you can go up to the maximum dose of 600 milligram. But we have n number of patients. Minded Indian patients do not tolerate 600 milligram. It's very, very high dose. One, because of cost. Second, because of side effects. And side effects is mainly because of somnolence and nausea. It significantly leads to somnolence. You have to be very careful about that. Gabapentin nobody uses now because of again side effects, and you can use till the dose of even 3,600 milligram of gabapentin. So regarding a combination of pregabalin and the methylcobalamin, now this is very common combination that is given. So there have been no, I would say, a randomized trial to use this combination. Again, this is a kind of irrational combination, but still it is present in the market. If you cannot supplement methylcobalamin, you give it. Even if you don't add methylcobalamin, it does not matter. It's only the pregabalin component that is useful for our patients. The doses start with 75, gradually build to 150. 300 is maximum for Indians, but yes, for American patients, they have seen even 600 milligram.
Yeah, it's one on.
100.
That's about painful neuropathy. But what drug will you use in a patient who has negative symptoms? Insensate.
That's the biggest challenge. So if a patient is having insensate foot, no drugs would help. And what he needs is a good footwear. What he needs a good counseling or self-examination of foot. Because he would land into a trouble, he will bump into an omni object and he will develop an ulcer. So self-examination of foot, training of that person, and a good footwear, an offloading footwear or a modified footwear. That's the only pill that you can use for these patients.
The next question would be, how long can we give pregabalin and gabapentin?
So, so people have given the trials are even up till 2 years, but there is no upper time limit for this pregabalin and gabapentin. But usually it is given up till the symptoms last, and we have seen in our practice that usually the symptoms usually wane. Painful symptom wane in around 6 to 12 months. So you can give up till 12 months, and if the still it they persist, you can go even up to 2 years.
Yeah. Is there any role for vitamin K in neuropathy?
So regarding role of vitamin K, the vitamin K has been seen especially in related to the CGRP, that are neurons with neuron terminals which are responsible for carrying of the pain sensation at dorsal root ganglion. But again, this is a placebo effect. So even if you give, even if you don't give, the trials have not shown any benefit of giving vitamin.
Role of microangiopathy in DPI.
Definitely, neuropathy is a microangiopathy, no denial of that. It is a microangiopathy, and it is basically the involvement of small nerve vessels that supply the nerve, that is called vasa nervosum, that are involved in patient with diabetes that lead to diabetic neuropathy. And therefore, if you remember, people have tried to give some kind of even nerve growth factors which can improve the vascular supply of these nerves and can improve neuropathy. But again, all of these are experimental trials. Nobody knows much about them.
Any role for PRP?
Again, PRP people have tried mainly for healing of foot ulcers, mainly neuropathic foot ulcers. For treatment of neuropathy per se, maybe positive sensation, negative sensation, no role of PRP.
All right. I think questions end over here.
Mm-hmm.
So, I'll submit it for you. So Dr. Ashu has spoken today about DPN, about the importance of early detection, positive symptoms and the negative symptoms, and how to arrive at a diagnosis, excluding the other causes which are also likely to occur in a diabetic patient. And then he has touched upon the treatment. He has also talked about the role of neuropathy in diabetic foot. He has also told you about how the diabetic foot ulcers, ischemic ulcers and the neuropathic ulcers vary, and how do you approach them, how do you treat them, and most importantly, something about Charcot's, which we all have to remember. So this is, I have just summed it up for you about what all we have spoken about today in this webinar. Would you like to add something, Ashu?
No, ma'am, it was a great experience sharing with all the physicians who has given their time to understand neuropathy. So it's important. Recognition and this simple examination is important. That's the only crux of managing these patients with diabetes or neuropathy and diabetic.
I think I thank Ashu for giving an excellent presentation. I thank the sponsors for having given us this opportunity and make this possible. And of course, I personally thank Diabetic Food Society of India for having given me this opportunity, and Dr. Ashu also. And we'll close the session here. Thank you very
Thank
much.
you. Great time. Bye bye.